All right, well, hi everyone. Thank you for joining us today, either whether you're listening to a recording or here live. My name is Kallio Hunnicutt-Ferguson. I'm a psychologist with Emory's Center for Maternal Substance Abuse and Child Development. I'm a psychologist, I have a clinical practice, and then I also work as a prevention specialist with the Emory Center for Maternal Substance Abuse and Child Development, which is my work with that group is what brings me here today. We are going to be offering a series on tools for parenting a child with FASD. Today, I'm just going to be providing an overview and then of some of these tools and talking about some of the neurodevelopmental impact of FASD as well as the intervention areas. And then we will go into more detail about some of these areas in the other scheduled lectures in the series. And so for those of you who are here live, feel free to either put any questions in the chat or shout them out at any point. I'll also leave some time at the end for questions as well as to talk about some resources. We always just have to acknowledge whether we have any conflicts of interest to report. I do not have any, and also just want to acknowledge some of our funding resources. So just an overview of my talk today. So as the introductory session of this series, I have a few goals. So I want to provide you all with an overview of that neurodevelopmental impact of FASD, provide information about the different intervention areas for children with FASD, and then again, save time at the end for questions and to provide some resources. And I do have a QR code at the end for, we would love any feedback. There's a survey that we'd love for you to fill out at the end. It is not very time intensive, but any feedback that you have for the presentation is welcome. So I found this quote by Diane Malbin, who is a leading expert in the field of FASD research, diagnosis, and intervention. And children with FASD are 10-second children in a 1-second world. And I liked this quote because I think it really ties into a lot of what we're going to discuss today in terms of the different impact on development for children with FASD. She has a book also called Try Differently Rather Than Harder. And I think it just highlights that at times the world as it functions is not always supportive of children with FASD and other childhood disabilities. We know that children with FASD really benefit from slowing down, from repetition, from consistency. And often we have to kind of change our expectations of their ability based on their developmental level versus their numerical age. But there are also interventions that can help if we can adapt in ways to kind of better fit their unique needs. So better fit that 10-second world versus the 1-second world. We don't want to take a one-size-fits-all approach with these kids. So the first part of today, I want to spend just talking about the impact of prenatal exposure to alcohol, focusing on fetal alcohol spectrum disorders, the pattern and symptoms that we see, and then I'll get into the interventions that focus on those different areas. So FASD is the most serious consequence of alcohol exposure in utero. And we have some recent studies that looked at FASD in first grade children across the United States. And these studies found the most conservative prevalence estimates for FASD ranged from about 1 to 5% or 11 to 50 per 1,000 children. However, some of their estimates were actually even higher, so about 3 to 10% or 30 to 100 children per 1,000. So these rates are just to say that FASD is more common than we maybe previously realized, and highlights the importance of really improving the interventions that we have available to children diagnosed with FASD, as well as increasing our support for the families. So FASD, many people think of FASD as a childhood disorder, but it does have kind of lifetime impacts. So some of the primary disabilities, we will go into these in more detail, but some of the primary disabilities include intellectual deficiencies, developmental and learning disabilities, as well as some more medical problems, cardiac problems, vision and hearing loss, facial dysmorphia, and some motor dysfunctions. And then secondary disabilities, which what we mean by that is those that may result from those primary disabilities, can include school failures, mental health, psychiatric problems, vocational failure, or legal problems. And because of the different problem areas, we want to recognize what can be kind of the burden of care on the families. There are many different service areas that these children and then adults may need. There are issues in physical health and motor that they may need services for, eye exams, cardiology, neurology. There may be developmental and cognitive impacts and needs in terms of assessments, speech and occupational therapy. There may be behavioral or social support that's needed, parent education training, psychiatric care, social skills training, and then academic and vocational supports. And always, I think it's important to talk about protective factors as well. So even with prenatal alcohol exposure, protective factors for children with FASD include living in a stable and nurturing home. Fewer changes in household is typically protective, not being the victim of violence, having received developmental disability services, and having been diagnosed before age 6. So we know that the earlier the interventions can be started, the better. So getting into the neurodevelopmental impact of FASD, there are a number of developmental disorders associated with FASD, with patterns in impairment and intellectual and cognitive ability, academic skills, and behavioral deficits listed here. And each of these different areas can influence each other. And we think that there is one common factor that actually contributes to the difficulties seen in each of these areas, which is what we call this impairment in arousal and regulation of arousal. And so we'll talk a little bit more about what that looks like when in kids and what we might see. So just a bit about why we think children with prenatal alcohol exposure have behavior problems. So many children with neurodevelopmental damage have behavior problems, and specifically in their ability to control arousal and develop appropriate self-regulation. And it's likely that these children have some inefficiencies in the brain in the areas that support the regulation of arousal and behavior. And this may be due to an effect on a specific region of the brain. So this diagram here shows some of the different areas that are impacted. But we do think it's more likely that it's more of an issue of brain connectivity, or meaning the ways that these areas of the brain communicate with each other. And environmental factors are also certainly a major contributor to the development of these skills. So this speaks to those protective factors. The need to meet these kids where they are can increase the likelihood of success. So some of the early signs of arousal dysregulation include greater, this can be seen often as early as infancy, so greater stress reactivity, impaired state control, sleep disruption, and negative affectivity, having more negative emotions. And then getting in, looking at children in the school years or older children, we may see some additional patterns that can include mood lability or moods that feel like they come out of the blue or kind of switch quickly from one strong emotion to the next. We can also see negative affect or irritability, frequent behavioral outbursts. We can see some difficulty in coding new information, learning new skills, difficulty shifting attention, difficulty going from one activity to the other, difficulty sustaining mental effort, so continuing with the task, particularly if frustration comes up, and also impairments in inhibition or impulse control. Now, focusing more specifically on these areas that are shaded in the darker color, intellectual and academic deficits. One, going back to that common factor of difficulty with arousal regulation, that certainly we know impacts academic skills and cognitive abilities. And so there are a few different patterns or clinical profiles that we might see in academic and cognitive deficits. We may see intellectual disabilities with significant physical findings. So an IQ in the average range is typically around 100. And so an intellectual disability is diagnosed if the IQ is less than 69. We may alternatively see IQs more in what's called the borderline range, 70 to 85. These children may have had a history of foster care, may have some specific learning deficits and behavior problems. We interestingly see that often reading and spelling skills are consistent with the child's IQ, but we may see a split in if they're tested, see a split in their scores to where they may have significantly higher language compared to performance skills. And the performance skills often require some executive function. They often test skills in math and spatial abilities. And so we may see what are called nonverbal learning disabilities, and again, specific learning problems with executive function and math. And so, as you may expect, that with these different clinical profiles, school completion may be negatively impacted. In terms of general learning ability, we see some learning impairments that may slow down the rate of learning. And so kids with FASD may need more trials or experiences with a concept to be able to learn the skill. They may need a more active learning experience, so doing rather than reading about or being told. And they often need to or benefit from exploring, experimenting, talking about, and moving around materials to help with the learning process. So in going back to that quote from the beginning, this is the 10-second child. These are the approaches that can really support that 10-second child and help them to learn. We may also, we mentioned earlier that often we see some difficulties with executive functioning and math. We also see often visual motor and graphomotor skills deficits. And so this picture shows the product of an intervention that focuses on handwriting and number skills. And I'll talk more about that in the overview of interventions. But we know that graphomotor and visual motor skills can improve with training and support. Math is a subject where being able to see and understand spatial relationships is really important. Knowledge of the size, quantity, and magnitude or intensity of different objects is influenced often by early visual spatial recognition. And so if there are deficits, then we're going to see deficits in math. Recognition of symbols used to represent numbers or mathematical operations is necessary as well for math, success in math, as is the ability to line up columns and do advanced addition, subtraction, and multiplication. So if there are deficits in these areas, we're going to see difficulty with math as well as these graphomotor skills. And graphomotor problems can then interfere with school performance. So we may see writing fatigue where they get tired after writing even for small periods of time. Handwriting may be hard to read or sloppy or messy. Organization can be poor, where letters are kind of scrunched up towards the beginning of a line, and then there's a bunch of space at the end of the line. And numbers kids may have difficulty writing numbers neatly even with lined paper. So another area of deficit that may explain some of the problems that we see are problems with what's called working memory, or this is also known as the small amount of information that can be held in the mind and used in the execution of cognitive tasks or tasks that require thinking or a multi-step process. And this is in contrast to something like long-term memory, which relates to the vast amount of information that we save about one's life. So we may see problems in any of these different areas. There can be auditory or visual processing problems, problems with short or long-term memory, retrieval from long-term memory, as well as manipulation in that short-term working memory. So for example, if we take a task like solve this problem in your head, 17 minus 9 equals, if we break that task down into all its different parts, we have to hold in working memory the instruction as well as the specifics of the problem, the numbers, the minus and equal signs. We then have to pull from long-term memory, what do these numbers mean? And what does it mean what does subtract mean? And then we have to correctly manipulate the numbers to get the answer. And so in theory, a somewhat straightforward math question, if we really break it down into all the steps that are required, if we have a problem at any of these different areas or steps, then we're going to have trouble solving the problem. And so just an example of how for kids with FASD, it may be that there's kind of a glitch in one of these steps. And so if we can teach them some of the skills that are related to any of these steps, then we can help them learn to learn these skills better. So I've now kind of summarized some of the main neurodevelopmental impacts for children with FASD, including those behavioral, academic, and cognitive and arousal regulation deficits. And so I'll now talk more specifically about some of the interventions. And again, just to kind of repeat an earlier point, one thing we do know about interventions is that the earlier, the better. And another piece that's important to discuss is the stress on the parents or caregivers. High level of parenting or caregiving stress is often reported in caregivers of children with FASD. And so there really is a need for interventions to equip parents with tools for reducing parenting stress, learn about effective parenting strategies for these kids' unique needs, increasing parental self-efficacy, and fostering the positive parent-child relationships. And many of the interventions that I'll talk about today do include a parenting component, and this is often very important for how effective the intervention and helpful the intervention is. So in terms of the intervention areas for children with FASD, there are several different domains that the interventions fall under. So there are self-regulation skills, academic skills, social skills, and then what I'll start talking about today is the safety skills. These are kids with brains that really struggle to do multi-step tasks. Sometimes they're described as being non-compliant, but it's really not that they're kind of doing that on purpose. It's more that they may not have understood what was asked. And going back to that math problem, there may have been a lack of understanding at one of those steps, so they may not have even understood what was being asked of them. But we'll first talk about safety skills that are one area of intervention, and it's an important area of learning and a type of social skill in a way that can include skills related to stranger awareness training, good touch, bad touch, fire safety awareness, and moving into the teen years, phone safety and some other kind of life adaptive skills. Children with developmental disabilities and behavioral problems are in general at elevated risk for unintentional injury, given impulsivity problems, poor judgment, and difficulty generalizing skills across contexts. And so there have been these pictures with the dog depict virtual reality games that have been developed to help to teach kids these skills. Do2learn.com is a great resource and has some of these different games and different exercises that can be taught. And then Moment to Moment is a documentary that covers teens who are growing up with FASD. Adaptive and independent living skills become particularly important during that time. And again, because of impulsivity and poor inhibition, kids or teens with FASD may engage in unsafe behaviors unknowingly or unintentionally with less forethought, which in general is a problem for teens, but can be even more so for teens with FASD. So we'll talk a little bit more about the teen specific skills and interventions in our teen session that will be happening in a few weeks. So another domain that's really important is that of social skills. And social skills interventions for teens with or children, young adults with FASD really target, these kids may be social, very overly social even, or socially disinhibited. They're often very interested in social interactions, but may have a hard time reading social cues due to some of their visual spatial issues, maybe having that cause some difficulty reading, for example, nonverbal cues. And a lot of work is needed to improve these social skills. It's a patient population who can feel very socially isolated and can be rejected socially because of maladaptive attempts to connect. And it's really important to intervene in this area because we know that poor peer relationships can be associated with some other negative outcomes like early withdrawal from school and delinquency, as well as the development of anxiety and depression. So many of the studies looking at social skills interventions involve parents or peers to help facilitate the learning of skills. And interventions include individual and group therapy targeted by age or developmental level. And the goals, the interventions can cover communication skills like learning nonverbal communication, listening and conversation skills, perspective taking. So that's a skill that's often difficult for children with FASD. So being able to understand how the same actions might affect somebody else or how somebody else might feel in the same situation. Joining others, sportsmanship and teamwork, as well as assertiveness skills. We also see interventions targeting more emotion-based skills, so dealing with teasing, learning to compromise, learning impulse control, and anger management skills. So one of the most common recommendations our center makes is a program called Beyond Words. And Project Good Buddies is another program in which children with FASD are matched with a peer. So these are some of the evidence-based interventions that we know of that target the social skills training. So next we have interventions that target academic skills, where most of the research with FASD has focused on these more academic skills. And MILE is an intervention that we will talk about in more detail in the educational intervention seminar, but I'll provide a brief introduction to it here. So we talked earlier about how we particularly see math deficits in this patient population. And so these are some of the patterns in math deficits that we see. MILE was originally tested in a group of children aged 3 to 10. This intervention has been replicated in many different settings. So the MILE intervention targets visual spatial confusion, fine motor problems, there's handwriting practice, problems understanding time and direction, and difficulty learning to count. It also targets difficulty with reading, writing, and copying numbers, confusion between adding and subtracting, difficulty understanding symbols. Often the number line, the vertical number line, which is often how math skills are initially taught, is challenging. And so the MILE intervention finds alternative ways to help kids learn math. And this is just to say, we don't think it's necessarily just a problem for math skills in particular. Math is more of a marker of underlying core deficits that interfere with learning in this area. And these core deficits impact these different skills that we've already referenced. So motor skills, arousal regulation, visual spatial skills, and learning. And then teaching methods can address these core problems. So the components of the math intervention in MILE include parent and caregiver training, a manual regarding math development and FASD, individual discussion regarding the implementation of home math stimulation activities, so the homework that's given to kids. There's a child tutoring component, a 6-week IEP developed using a curriculum, and then 6 weeks of one-on-one tutoring sessions. And then a teacher training that includes instruction on FASD and impacts on math abilities, discussion regarding that child's unique neurodevelopmental profile, and then information about the 6-week IEP that is developed. And so this is just an example treatment plan. So at the end of the 6-week tutorial sessions, child will be able to correctly print numbers from 1 to 10, correctly describe same, different, more or less, correctly identify spatial relations such as up and down, over, under, beside, between, correctly sort and classify groups according to different dimensions, understanding underlying concepts of addition and subtraction, writing the number sentences for sums up to 5. So in terms of the outcomes of MILE, we have seen positive gains from the parent education portion. So positive gains in terms of neurodevelopmental understanding of neurodevelopmental deficits, arousal regulation, behavior, and learning, and as well as on the behavior management and social learning principles. We saw that what was particularly helpful with the interventions was when they provided scaffolding according to the children's unique learning needs, as well as integration of strategies with school and family. So it's of course very important that the strategies are being consistent across settings. The instruction supported growth in areas of the specific deficits seen for the children, and was most effective when it incorporated what are called metacognitive strategies, ways to integrate information, providing frequent review and repetition. So finally, we have the self-regulation domain of intervention research. And again, this will be discussed more in one of the other sessions, but just to provide an introduction, the FAR metacognitive strategy is used in MILE, the math intervention I just mentioned. And this teaches children how to learn to generalize the skills, so that those metacognitive skills, or thinking about thinking skills. And this involves showing these kids cards for each problem that they're approaching. And then in the behavioral regulation training, these are then applied to more adaptive skills. So the first step is the F is focus and plan. This is orienting the children to thinking with their brain, making a plan, look carefully, listen carefully. So again, really kind of slowing down and thinking through ahead of time what they're going to do. Then the act, the try it out, do fun stuff and learn. And then afterwards, reflect on what they did. What did you do and what did you learn? And that's really helping them think about the process, and really that's aimed at helping them learn to think about thinking and then to generalize the skills to other areas. So the FAR cards are applied with the self-regulation training to more of those self-regulation skills and an intervention that we call Go Far. And this intervention that our group actually developed it does involve a virtual reality computer game that helps kids learn these skills. And the goal is to reduce disruptive behavior using this program, and parents are given basic education again regarding FASD, some of the behavioral regulation learning principles, and how to use that FAR technique to teach their children some basic life skills. So behavioral regulation principles focus on teaching parents to really identify when the child is getting to the point of no return and kind of intervening earlier. So children with FASD seem to learn best when they are in this calm alert state. So the middle of this curve here. So once they're starting to get to excited alert or upset crying, they're not going to be able to learn as well. So we really want to help parents. The goal of the training is to help teach parents how to identify when the child is in the calm alert state, and maybe when they're getting to farther along in that curve so that they can intervene earlier. And the adaptive skills that are a focus of behavioral regulation training include things like morning and bedtime routines, going to the store or restaurant, getting ready for school, doing homework, social interactions, and animal care and safety. So in terms of intervening, for example, if you're at a birthday party, at what point might you need to pull the child into another room to calm down? So key modules focus on learning what are social learning principles, how do I modify my child's level of arousal, how do I modify my child's world to prevent problematic situations, as well as how do I get my child to comply in situations where that's needed. So just to summarize, the key features that we think are really needed to help improve learning in these different domains are an appropriate environment, often a simplified learning environment, again, slowing down and meeting the child where they are. Providing a setting that reduces the chances of failure or making wrong choices, reducing frustration from the child on the part of the child, as well as monitoring arousal and teaching in those calm alert states. And finally, I think it's important to talk about the future of interventions and some of the gaps in our knowledge, really. So we really want to improve access to care. That's definitely an issue with our current healthcare system, and also fill in gap areas. So really there's a lot of, a huge gap area is in teens and young adults kind of aging out of the school system. So 18 and up, there's just really not a lot of services or research to support interventions in this area. We really need to take a lifespan approach to that point. And we want to reduce the timeline from bench to bedside. So right now there's often a long gap between when a parent might suspect a child may have FASD and when they're diagnosed, and then when they get intervention. So we really want to, again, start to diagnose and intervene as early as we can. There really is not a lot in terms of developed pharmaceutical interventions for children with FASD, and we need to continue to improve and expand upon the evidence-based treatments that we do have. So I talked about the different interventions that are available, but many of these studies have had very small sample sizes and not really been replicated very frequently. And so we need that increased focus. So I want to conclude by talking about a few different resources. So at the state level, we have the Department of Community Health, Division of Public Health. An example of one of the services for children with FASD is Babies Can't Wait. And then the Emory Neurobehavior and Exposure Clinic is a multidisciplinary assessment and treatment clinic for complex problems. This is the clinic that our group runs. And the mission of ENIC is to serve children ages 0 to 21. We focus on diagnosis and treatment of effects of prenatal exposure to alcohol and drugs. We use a developmental context. So again, going back to that idea of we really want to focus on developmental level versus necessarily age. Taking into account different environmental factors that we know influence development. And we take a multidisciplinary perspective. So we have pediatric services, psychiatric services, so medication consultations, as well as psychological and educational. So this can include differential diagnosis, developmental and psychological testing, behavior management, and parent coaching. And then from the educational side, special education consultation and testing, consultation with schools, and a Saturday cognitive rehab clinic. So some additional resources for children affected by maternal substance use. We have MotherToBaby Georgia's affiliate is affiliated with our group as well. And they are this is often for pregnant women or any parent or caregiver that has questions about exposures. You can call or text. There's a chat available via the website. Again, Babies Can't Wait's website is listed here along with Emory's Neurodevelopmental and Exposure Clinic. And there's also GCAL is another resource for finding resources in Georgia. We also have an ENIC resource guide that we can provide if you are interested. You can send us an email and maybe I don't know the best way to provide that email, but maybe I don't know if I put it in the chat, I don't know if it will be available in the recording, but we can get that to you all if you are interested in the resources. I believe, Devin, if you're there, the email is msacd.emory.edu, I believe.
Yes.
Is that correct? Yes. Okay. So msacd.emory.edu. Just send us an email if you're interested in receiving that resource guide. So that is the end of today's talk. I definitely am here to answer any questions anyone has. And I have our QR code here as well as the link if you prefer. We'd love feedback on the talk or anything else you'd be interested in hearing about. But I also, again, want to provide or stay on for if anyone that's here live has any questions.
When I provide the recording, I will put your email at the end as well.
Great. Great idea. Thank you. Well, thank you all for being here. I'll stay on a little bit longer just in case anyone has any questions, but otherwise people are also welcome to reach out over email with any questions as well.
I have a question for you.
Sure.
And you said you were going to cover this in another session, but I myself, and I also work with some clients as an advocate where predominantly their kids have been diagnosed, let's say older, 9, 10, going into the teen years and that type of thing. And I guess I'm trying to understand the Emory Clinic, because I know when I've called down there, I was pretty much told that it was to do, a psychological evaluation, medication, and some of these kids have already gotten some of that, but I wondered, are there resources that the clinic can provide for kids that are in their teens and young adults, and what would they be?
Yeah, so that should be in the resource guide that we have.
Okay.
I will talk more so one of the shorter answers is that unfortunately for teens, that's an area where there's just been very little kind of resource or research and intervention.
Right.
I think often the most kind of data or information we have is almost more related to those secondary disabilities. So often the interventions target more like emotion regulation skills, other comorbid mental health problems that may be coming up in the teen years, like depression and anxiety or impulse control problems. As well as substance use issues. So kids or teens with FASD are at greater risk for developing a substance use problem themselves. And so a lot of the interventions have a component that targets prevention of substance use problems. So and adaptive skills is also a focus. So kind of like safety and adaptive skills, how to kind of increase independence, and depending on the age and developmental level, potentially independent living.
Right, that's important.
But yes, we can definitely provide you with the resource guide. Off the top of my head, I'm not as familiar with some of the specific resources for teens, but it should be in that guide, and we can happy to provide that to you.
Okay, thank you.
Sure. Thanks for being here.